Okay, Chapter 11. Chapter 11 starts out talking about how in the early 1800s, our way of taking care of each other when it comes to medical needs was much like the Amish. We were very close communities, close akin to each other, and were able to provide support when someone in our community or our families needed it. And maybe that meant gathering up, putting money together, pulling together, and getting that need met. That began to change as urbanization and industrialization happened in the middle 1800s. Ties became more loose. You were living around people that were not your families. You were living in different types of communities. And this began to cause people that had certain types of accident-prone jobs to start getting this traveler's insurance that helped you if you were become in a major accident, which helped with your family being at financial risk. So it didn't look anything like it does today. If it was to resemble anything from today, it would be more of the like the accidental coverage, where if you were just something happened, you were off work for a broken leg. After that, the next thing was in 1864, the Travelers Insurance Company of Hartford. This is the first insurance company that began to cover actual physician coverage, but it only covered up to a 21-day stay in the hospital. But by 66, in 2 years, we had 60 different insurance companies in the United States. In Germany, in 1983, in Germany, they began and passed their national health insurance coverage, which gave insurance to all citizens there in Germany. That was followed up with Woodrow Wilson in 1904, attempted to adopt national health care coverage in 1904, Woodrow Wilson, but when some of the support that he had, realized that within that policy that he was also going to put limitations on reimbursement and control the medical cost coverage, he lost a lot of support and it didn't go through. And then when the Great Depression happened and a lot of things changed for a lot of people and a lot of people lost stuff, there became this new idea of how much the government needed to step in and help with insurance coverage. So in 1929, Blue Cross Blue Shield began to provide some coverage for medical providers. But by 1937, they began to actually have plans, like insurance plans, similar to what we see today. And up to this point in time, all those insurance plans that did help with medical expenses still only covered physicians or hospital stays. And then the World War II. So after soldiers started coming back after World War II in 1950s and 1960s, all of these events created a major boom for insurance companies springing up everywhere, providing insurance coverage everywhere. The reasons that the coverage was, the reason that after World War II, there was such an influx of these insurance companies being created. And at the bottom of page 264, it tells you why. It says, first, it excluded health insurance benefits from wage and price controls. So there was no price controls. And secondly, it excluded employees' contributions to their health insurance coverage from being considered taxable income. So those two things caused it to boom up really, really quick. And a lot of people buying in. In the 1950s and 1960s, the expansion of benefits it's talking about was those insurance companies started providing dental, vision, prescription coverage, and mental health coverage. And because they started providing mental health coverage in 1963, when the Community Mental Health Act passed, then all these community mental health providers further helped insurance companies and people decrease some of the stigma that was attached to going to a counselor, because they were now included in the insurance plans. The cost was ridiculous. The cost rose so fast. It was up under this idea, this such stringent idea that the doctor knew best, just do whatever the doctor says and let them lead the way, and we just got to spend whatever it takes. That idea began to change in the 80s, where they were like, I don't think so, because in 65 we spent $42 billion in medical payout, but by 1985 we spent $442 billion in payout, and within 7 years that doubled to $800 billion in payout for medical services. And so those are the things, that crazy increase, that crazy rate of how fast that number is being climbing, is what led to managed care in the first place. Because of everything increasing so fast, one of the thoughts of maybe why this is happening is that people aren't necessarily being honest. And so there was some studies done, and they found out that 54% of the people diagnosed were updiagnosed, which is illegal and fraud. So when they audit charts, they can get money back for these type of things, because it's illegal and it's fraudulent. You get a lot of trouble. And then they began with this idea to keep costs down and to keep people from requiring necessary and unnecessary appointments. They began this idea that we can do cost containment. And that's where you get, for every unit, you get paid a certain amount of money, but that's also factored in with the outcome that we want. So the idea of managed care is for us to get our best bang for the buck with good results. The definition of managed care: a range of programs and policies that control access to care and the types of care delivered and the cost of care. So to kind of keep it all reined in. And it talks about 3 different primary provider types of managed care, which is HMO, PPO, and POS. The best thing about HMOs is that they really do work hard to keep those premiums and out-of-pocket expenses down, and no deductibles. And that's a big plus if you have an HMO. The PPO, they have network of providers. So they go and they have people come in, and they have, like, when you refer, you get this whole network of providers, whether they're specialist or primary, but they all work in this one network. And the service plan, POS, they try to combine basically the two. They allow you to have the doctors you want, like you can have in the HMOs, but they have in-network and out-of-network at the same time, while trying to control the cost. There's a little bit of differences in each one. Other things that they do to reduce costs is pre-authorization. Pre-authorization is really something that is required when their insurance company says, okay, I'm going to let you go this far, but if you go any amount past this point, then we have to approve any more payments that we're doing for whatever that procedure is. So it could be for a specific procedure, a specific service, a continuation of services, or even a specific medication. They have to approve it before it gets any more costly. They have to make sure it's necessary before they're going to pay for it. Concurrent utilization reviews. This is audits. That's what it is. It's audits. So if they think that you're doing something wrong, they can audit you. If they want to check in the charts, they can audit you. They can justify that you are doing what you're charging for. And then there's also incentives for you to be in their networks, because in their networks, when you're searched, and if you live in this area and you search for network providers and they've joined your network, then that doctor comes up on that screen and you know that they're on that network. They also have a list of what diagnoses are acceptable. They want you to practice brief and goal-oriented services, whether you are Rogerian or Gestalt or whatever theoretical base that you when you did that thing at the beginning of the semester, whatever theoretical base that you really shone brighter in, you still need to make sure, because of this type of stuff, you still need to know a little bit of motivational interviewing. You still need to know some brief therapies, because sometimes you're going to get somebody and they're only going to get 3 to 4 services. You're only going to get 3 to 4 sessions period with this person. And so even if you're normally very Rogerian and you want to take your time and let that person go, there's going to be clients that you can't do that with, because you're not going to get where you need to get with them, and you're going to have to know some brief therapy. And that's another way of keeping costs down. And then you've got the cost being shared across the board. So the employer's paying a portion of it, the employees paying a portion of it, the insurance company's paying out, but they're paying out to the provider for a contracted amount. So they're trying to level out the payments to where everybody shares it. Different ways that you can join these systems are one of the way that the book talks about on page 270. It's called capitation. This one is kind of very tricky, I think, okay? Because basically what they're saying here is they're saying we have 1,000 people in our insurance plan. That's within your system. And out of these 1,000 people that are in our insurance plan, then we're going to pay you $1,000 a month to provide services to any of them that need you. It doesn't matter if they come or not. We're still going to pay you $1,000. So that provider is not going to, come on, I'm going to get the same amount of money either way. I'm not going to ask you to come in weekly instead of monthly, because I'm getting the same amount of money either way. So if I see 10 people for this month, then 10 divided by 1,000 is 100. And so I'm making $100 a visit, compared to if I seen 100 out of the 1,000, where I'm only making $10 a visit. So that really is cost effective on the insurance end, but it definitely does not motivate the provider to do a lot with those that they're serving. So that one to me is a little bit tricky. There's pros and cons to everything. Other things that they want you to look at is less but equal treatment. They can look at medication being a lesser economic, lesser expensive service, and say that they would rather you take the medication than do talk therapies, because that may cost more. Again, the claims review, looking into the charts, looking in the diagnosis, looking in the services, making sure there's no fraud or anything that's happened. Those are ways to keep costs down. And then the integration of services, putting a lot of services under one umbrella. We talked about that was already one of the things that's really big, is these primary care facilities really bringing in mental health workers into their offices, so that they have this umbrella of care, that's cost effective. One of the things about the improvement in the health care system is that they have to have these requirements where they are covering psychiatric and behavioral health. And so we used to not have service provided for like inpatient substance abuse addiction treatments, and now we do. So there's definitely a lot of good that's come out of these type of things. They do push for this team-based approach. They're trying to keep costs down to where everybody can afford it. Providers are encouraged to do integrations of care, because you get reimbursement for episodes of care, which is bundled services. And you have to know that every time something happens, every time something changes, every time somebody up way higher than us thinks that they know a better way to do it, things change. If you're in this field and you have to do any paperwork, whether it's in your agency, whether it's in your state, whether it's the federal government themselves, You will constantly have to adapt to doing things differently every time they change. So the one thing that you need to accept is change is inevitable and it's coming, and you need to be flexible with it, because otherwise it's just going to be one of those things that's going to highly irritate you. Change is inevitable. Just know that, accept it. And although we talked about pros and cons to different changes in the mental health system, you have some providers who are just trying to navigate the system, figure out how to get the best care for their clients, do what's best for their clients. You have some clinicians that are just like, absolutely not. I'm going and I'm putting my own shingle out there. I'm doing cash only business. I'm not dealing with all this crap. I'm going to just take and charge this amount of money per session, and people can pay me out of pocket. No insurance reimbursement, period. And then you have some people that are looking at this in a holistic manner of what's good and what's bad, and the bad they feel may be detrimental to services in some way. They're fighting back. They're being advocates for clients, and they're protesting and want to see changes. So they're trying to overthrow this system and make it a better one. So again, how you react to a system, how you view it, and how you work within it or challenge it, those are all different things that we do in mental health at different times. But that wraps up the end of chapter 11.